Welcome, everyone. We are so glad you're joining us today for this deep dive.
Absolutely. It is great to be here to get into this one.
Okay, let's unpack this. Think about how many times you have coughed in your life.
Oh, it has to be in the tens of thousands.
Right. It is such a common, everyday occurrence that we barely even register it happening anymore. You get a little tickle in your throat, you hack a couple of times, you clear your airway, and you just move on with your day.
Yeah, it is entirely background noise.
Completely. And if you have children, you know this soundtrack intimately. I mean, the clinical sources we are diving into today highlight that school children experience an estimated 7 to 10 distinct cough episodes every single year.
7 to 10. That is practically one a month during the school year.
It really is. And as adults, we are still dealing with 2 to 5 episodes annually. It is quite literally the background noise of the human experience, especially right in the middle of those winter months.
But the thing is, underneath that completely mundane, slightly annoying sound you make, there is a highly orchestrated, incredibly complex neurological and physiological event taking place.
And that brings us to our source material for today. We are exploring a really comprehensive clinical pharmacy text aptly titled Cough Clutter.
It is a fantastic resource.
It really is. It breaks down the physiology, the diagnostic flowcharts medical professionals actually rely on, epidemiology, and a remarkably candid, honestly somewhat shocking review of the evidence behind those over-the-counter cough medicines you buy.
The pharmacy aisle section is going to blow some minds today.
Oh, without a doubt. So our mission for this deep dive is to decode your body's ultimate alarm system. We want to help you figure out what different types of coughs actually mean.
And crucially, to separate pharmaceutical fact from some deeply ingrained fiction, so you can be a much more informed patient.
Exactly. So let us start with the physical act itself, the anatomy of a hack.
It really is a physiological marvel that we entirely take for granted, primarily because we only focus on it when it becomes an annoyance.
Like when you are kept awake at 2 in the morning by that persistent tickle.
Right, exactly. But understanding the mechanism completely changes how you view the symptom. A cough is not just a random irritation. It is a highly sophisticated 5-part reflex mechanism.
5 parts.
5 distinct steps. Its primary purpose is defense. It is your respiratory system's absolute primary method for clearing the airways of foreign bodies, particulate matter, and excess secretions.
So walk us through that journey. What happens when I inhale a speck of dust?
Tracing the anatomical journey reveals just how much computational power your body dedicates to this single action. The first step involves a vast network of sensory receptors spread throughout the respiratory system.
And these are located where, exactly?
You have them in the pharynx, which is the back of your throat, down into the larynx, the trachea, and crucially, right at the bifurcations.
The branching points.
Yes, the branching points of the large bronchi in your lungs.
Which makes perfect sense, physically speaking. Those branching points are where the airway splits, meaning they are the exact locations where inhaled debris or pooling fluid is most likely to hit the physical walls of your respiratory tract.
It is basic physics.
Right. Your body places the highest concentration of sensory tripwires right at those high-impact intersections.
Exactly. And these receptors, they aren't just looking for one type of intruder.
What do you mean?
Well, they can be triggered mechanically, like if you inhale a crumb of food. They can be triggered chemically by environmental irritants or the inflammatory byproducts of a viral infection.
Or even thermally, right?
Yes, which entirely explains why stepping out into a blast of freezing winter air can suddenly send you into a massive coughing fit. The thermal shock trips the receptors.
So the alarm is tripped. What is step 2?
Neural transmission. The stimulated receptor fires off a neural impulse that travels incredibly fast up your afferent pathways. In the respiratory system, these signals travel primarily along the vagal and superior laryngeal nerves.
So they act like the fiber optic cables of the chest.
That is a great way to picture it. High-speed cables carrying the intruder alert signal away from the lungs and throat directly up to the brain. Specifically, they terminate at the cough center, which is located in the medulla.
The medulla. The fact that there is a dedicated command center in the brain just for coughing really shows how critical this is for our evolutionary survival.
It is not optional.
Right. This isn't a localized peripheral reflex. It's not like when a doctor taps your knee with a reflex hammer and your leg kicks out without your brain really needing to get deeply involved.
No, a cough requires central processing. The medulla receives this alert, processes the severity and location of the irritation, and instantly fires back a coordinated command.
Which brings us to step 4.
Yes, where the efferent fibers, the nerves carrying signals away from the brain, travel back down the vagus and spinal nerves. But they do not just go back to the lungs.
They recruit backup.
They do. They direct their signals to a very specific, highly powerful set of muscles, the diaphragm, the chest wall, and the abdominal muscles.
Which sets up the physical explosion.
That coordination is where the physical power of the cough is generated. In the final step of this reflex, those targeted muscles rapidly and forcefully contract,
Shrinking the chest cavity.
drastically shrinking the volume of the chest cavity, which builds up immense, intense pressure inside the lungs. And while this pressure is peaking, the glottis, the opening between your vocal cords, remains tightly closed.
Holding it all in.
Until, in a fraction of a second, the glottis suddenly flies open. All of that trapped, highly pressurized air is released instantly.
And
Boom! That sudden, violent outward rush of air is what creates both the distinct sound and the sheer physical force necessary to dislodge whatever tripped the alarm in the first place.
it is a literal microscopic explosion happening inside your chest.
Every single time you cough.
But the cough is really the heavy artillery, isn't it? I mean, it is actually supplemented by a continuous background defense system. And I have to say, this system has perhaps the best name in all of human anatomy.
Oh, the mucociliary escalator.
The mucociliary escalator. I love it.
It is incredibly descriptive.
It really is. So for those listening, if you imagine the lining of your respiratory tract, it is coated in a thin layer of sticky mucus designed to trap dust, bacteria, and debris.
Like flypaper.
Exactly like flypaper. And beneath that mucus are millions of microscopic hair-like structures called cilia. These cilia constantly beat in a coordinated upward wave,
Physically pushing that layer of tract debris up and out of the lungs.
moving it constantly toward the throat where it can be swallowed or cleared. It is a literal escalator made of mucus and tiny hairs. And a cough usually only happens when that escalator gets overwhelmed, jammed, or encounters something simply too large to move gently.
Precisely. Because this dual mechanism of the escalator and the explosive cough reflex is so foundational to lung health, a cough is by far the most common respiratory symptom we experience.
It is the ultimate diagnostic check engine light.
It is. It is the primary and sometimes the only way your respiratory tract can signal to you and to medical professionals that something within the system is abnormal.
So when a patient actually goes to a clinic with this symptom, how do you start sorting it out?
Clinically, the very first distinction we make is whether the cough is productive or non-productive.
The classic 2 buckets.
Right. A productive cough is your classic chesty cough. The explosive force we talked about is actively bringing up sputum, phlegm, or excess secretions from the lower respiratory tract.
And non-productive.
That is generally described by patients as dry, tight, or tickly, with absolutely no physical material being expelled.
But, and this is crucial, there is a massive caveat to that distinction in the clinical text that fundamentally changes how you should communicate with a pharmacist or a doctor.
Yes, the perception versus reality issue.
Right. Often, you might feel a deep rattle in your chest when you breathe or cough, but nothing actually makes it all the way up into your mouth to be expelled.
You swallow it back down or it just shifts around.
Exactly. So if a professional asks you if you are producing phlegm, your instinct might be to say no because you aren't physically spitting anything out into a tissue.
Which leads to a misdiagnosis.
Yes. Because medically speaking, the text is clear. If you tell a clinician that you aren't producing sputum, but you, quote, can feel it in the chest, they must legally and medically treat that as a productive cough.
That phrasing is a vital diagnostic clue. If the sensation of loose mucus is present in the chest cavity, it means there's an accumulation of secretions down in the lower airways.
Usually secondary to an infection or inflammation.
Right. The fact that the physical force of the cough isn't quite strong enough to push it all the way up the trachea does not change the underlying pathology. It is still a chesty productive issue, and it absolutely requires a different diagnostic pathway than a purely dry, tickly irritation in the upper throat.
Right. Okay, so beyond the sound and the feel of the cough, the next most critical factor the text highlights is the timeline.
The medical clocks.
And this is where so much of our anxiety as patients originates. You get a cold, you start coughing, and after a week of terrible sleep, you are utterly convinced that you have developed a permanent, serious affliction.
We completely lose our sense of perspective when we are sick.
We really do. Day 7 feels like year 7. To counter that, the medical community relies on very specific definitions based on duration. According to the UK guidance from the summer of 2024, clinicians put a rigid clock on your symptoms. They divide coughs into three distinct categories.
Acute, subacute, and chronic.
Exactly. First, you have an acute cough, which is defined as being present for less than 3 weeks. Then you have a subacute cough, which sits in that incredibly frustrating middle ground, lasting anywhere from 3 to 8 weeks.
And finally, a chronic cough is one that has persisted for more than 8 weeks.
The gap between patient expectation and biological reality is quite vast here, isn't it?
Oh, it is massive. A patient might sit in a doctor's office on day 12 of a viral illness, feeling utterly exhausted, fully expecting the doctor to intervene because they genuinely feel the cough should have resolved by now.
Day 12 feels like you are dying.
It does. But physiologically speaking, an acute cough at day 12 is still well within the normal expected window for the body to clear a respiratory infection and repair the irritated tissue.
The tissue has to literally rebuild itself.
Exactly. Guidelines from the British Thoracic Society published in 2019 state clearly that the vast majority of coughs are entirely self-limiting.
Sure.
They will resolve on their own, but the normal timeline for that complete resolution is often 3 or 4 weeks.
3 or 4 weeks feels like a lifetime when your ribs ache from hacking.
It really does.
But knowing that timeline is actually incredibly empowering for the listener. It means that unless you're experiencing severe systemic symptoms, like a dangerously high fever, intense chest pain, or genuine difficulty breathing, you shouldn't panic on day 12.
Your body is just doing its job.
Right. Taking the time it needs to rebuild the cellular lining of your airway. It is only when a cough pushes past that acute 3-week phase without any other obvious signs of a fading cold that a medical referral for further investigation becomes the standard recommendation.
And moving from the individual experience to the broader population data, the epidemiology of the cough reveals the sheer scale of the burden it places on healthcare systems globally.
It is staggering.
When we look at general medical practice statistics in the UK, respiratory illness accounts for more patient visits to general practitioners than any other single disease category. It completely dominates the schedule.
And this isn't just a UK phenomenon.
No, global data echoes this overwhelming demand. In Australia, for instance, episodes of upper respiratory tract infection, or URTIs, consistently rank as the most common acute conditions managed in general practice.
The universal nature of human airways.
And the viruses that target them create a unified global health picture.
Which brings us to a major point. When we talk about what is actually causing all of these doctor visits, we have to look at the culprits. When you have a chesty cough and you finally go to the clinic, the immediate ingrained assumption for many of us is that we have a bacterial infection.
And therefore, we desperately need a prescription for antibiotics to make it go away.
Exactly. The old give me the Z-Pack mentality. But the epidemiological reality in the text is heavily skewed in the completely opposite direction.
The vast majority of acute coughs are caused by viral pathogens. The primary drivers are respiratory syncytial virus, commonly known as RSV, alongside various strains of rhinovirus and coronavirus.
Viruses, not bacteria.
Right. These viruses are highly adept at infiltrating the respiratory epithelium, taking over the cellular machinery, and causing the localized inflammation and cell death that trigger the sensory receptors we discussed earlier.
So where do bacteria fit in?
Bacterial pathogens do cause acute coughs, but far less frequently. When they are the culprits, the typical bacterial suspects include Streptococcus pneumonia, Haemophilus influenza, Staphylococcus aureus, and Klebsiella pneumonia.
Okay, so for decades, distinguishing between a viral attack and a bacterial invasion in a standard GP appointment was largely an exercise in clinical deduction.
A very educated guess based on symptoms.
Right. A doctor would listen to your lungs, look at the timeline, ask about your symptoms, and just make the best call they could. But what's fascinating here is there has been a massive revolution in point-of-care testing that fundamentally changes this dynamic.
It really is a game changer. As of autumn 2023, GP practices have begun utilizing new rapid immunoassays right there in the clinic.
Tell us about these tests.
This point-of-care advancement is crucial for accurate diagnosis and for global antibiotic stewardship. These new immunoassay tests require just a simple sample from the patient, and they simultaneously measure two distinct biomarkers. First, they detect C-reactive protein, which is a general inflammatory marker. Elevated levels indicate that the body is actively fighting off some kind of significant infection.
But that doesn't tell you if it's a virus or a bacteria, right?
Exactly. But the real key is the second marker, Mycovirus protein, A. This specific protein is elevated almost exclusively in the presence of a viral infection.
Ah, so it's a direct viral fingerprint?
Yes. By analyzing the levels of both C-reactive protein and mycovirus protein A together, a clinician can definitively differentiate between a bacterial and a viral respiratory tract infection within minutes, while the patient is literally still sitting in the consultation chair.
It completely removes the guesswork. If the viral marker is high, the doctor can confidently tell you that an antibiotic will do absolutely nothing for you, saving you from unnecessary medication and helping to prevent the rise of antibiotic-resistant superbugs.
It is brilliant technology.
But let's say you are at home, you don't have access to a fancy autumn 2023 immunoassay machine, and you are trying to figure out what is going on in your own chest. This brings us to the differential diagnosis portion of the clinical text.
Which is essentially a guide to reading the tea leaves of your own symptoms.
Or, more accurately, reading your own sputum.
Yes. We have to get a little graphic here because the visual characteristics of what you cough up are primary diagnostic clues.
Let's do it. Walk us through the color and consistency guide.
The color of sputum provides a direct window into the inflammatory processes occurring in the lungs. Starting with the most benign presentation, we look for mucoid sputum.
Which looks like what?
This sputum that is completely clear or white. Clinically, this presentation is normally of little consequence. It strongly suggests that there is no active severe infection present.
So just normal baseline irritation.
Right. It might be the result of a mild physical irritant, a lingering dry cough, or minor postnasal drip, but it does not signal a pathological invasion.
Clear and white means you are generally in the clear. But the moment that mucus changes color, panic usually sets in for people.
Oh, absolutely.
If you cough up sputum that is yellow, green, or even brownish, the immediate cultural assumption is that you have a severe bacterial infection that requires heavy-duty antibiotics.
This is perhaps one of the most widespread medical misconceptions that exists among patients.
Break that myth down for us.
It is a pervasive myth. The text is unequivocal on this point. While mucopurulent sputum, which is the clinical term for yellow, green, or brown phlegm, does indicate that an infection is present, it is generally caused by a viral infection.
Wait, green phlegm is viral?
Yes. The color change is a byproduct of your own immune system at work. When white blood cells, specifically neutrophils, rush to the airway to fight off a viral pathogen, they eventually die in accumulating the mucus.
And dead neutrophils are green.
Exactly. The cellular debris and the enzymes they leave behind are highly pigmented, which turns the clear mucus into that thick green or yellow substance. Therefore, coughing up green phlegm does not automatically mean you need a medical referral, nor does it mean you require antibiotics.
Your immune system is just doing its job.
Right. It is already successfully battling the virus.
That is such a vital piece of information to internalize. Green phlegm is a sign of a battlefield, but it is usually a viral battlefield. However, when the color shifts from green to red, the clinical calculus changes entirely, right?
Completely. Haemoptysis, which is the medical term for coughing up blood, is a symptom that always warrants careful attention.
The clinical guidance breaks down a danger spectrum based on the exact hue and presentation of that blood.
Context and visual specifics are paramount when assessing haemoptysis. The text details 3 highly distinct variations that point to entirely different underlying pathologies. First, if the sputum is rust-colored, this is a classic historical indicator of pneumonia.
Rust-colored.
Yes. The rust color comes from old blood mixing with the purulent material deep in the infected alveoli. Second, if the patient is coughing up sputum that is pink-tinged and frothy, we look away from an infectious cause and toward the cardiovascular system.
Pink and frothy means heart issues.
This presentation is a hallmark sign of left ventricular failure. The failing heart causes fluid to back up into the pulmonary circulation, forcing serum and red blood cells into the airways, which mixes with air to create that pink froth.
And the third variation.
Finally, the presentation of dark red blood is a severe red flag that raises immediate suspicion for carcinoma or lung cancer.
Those are terrifying associations for any patient to navigate. But before anyone assumes the absolute worst at the very first sight of blood on a tissue, the clinical text provides a very necessary reassurance regarding the mechanics of coughing itself.
Indeed, it does. The sheer physical force generated during a severe coughing fit, the explosive pressure we discussed during the anatomy breakdown, can be immensely traumatic to the delicate tissues of the respiratory tract.
It is a violent act.
It is not uncommon for a patient to produce a single, isolated event of sputum streaked with bright red blood, simply because a tiny superficial blood vessel in the airway ruptured under the strain.
So a burst capillary.
Exactly. If it is a single event of bright red blood, rather than an ongoing production of rust or dark red sputum, it is generally not a serious pathology and does not usually require immediate medical referral.
That distinction between a single bright red streak and ongoing deeply colored blood is a massive relief to know. Finishing up the visual and sensory assessment of sputum, there is also the factor of smell.
Yes.
If a patient produces sputum that is offensive or noticeably foul-smelling, what does that indicate to a professional?
A foul odor is a distinct and troubling clinical feature. It strongly indicates a localized pooling of mucus where anaerobic bacteria have been allowed to aggressively multiply.
So it is essentially rotting down there.
Unfortunately, yes. This presentation points away from a standard viral cold and directly toward chronic structural conditions like bronchiectasis, where the airways are abnormally widened and flabby, allowing mucus to stagnate, or a lung abscess, which is a localized cavity of pus and tissue necrosis within the lung itself.
Moving away from the physical characteristics of the sputum, the actual timing and duration of the cough provide the next set of clues. If you pay attention to the clock, your body often tells you exactly what is wrong.
Timing is everything in diagnosis.
For instance, the text points out that if a cough is noticeably worse first thing in the morning, it strongly points toward conditions where mucus has pooled overnight and needs to be violently cleared upon waking, like bronchiectasis or COPD.
Makes perfect physical sense.
Conversely, if a cough gets progressively worse in the evening or becomes severe at night, the diagnostic needle swings toward viral infections, croup in children, or the fluid accumulation associated with heart failure when lying flat.
To synthesize the duration aspect into a highly practical framework, clinicians often utilize what can be described as the rule of threes shortcut.
The rule of threes, I love a good heuristic.
It helps quickly narrow down the differential diagnosis based simply on how long the patient has been suffering. If a patient presents with a cough at the 3-day mark, the immediate, most statistically probable thought is a simple acute viral infection.
Just a standard cold.
Exactly. If the patient returns and is still coughing at the 3-week mark, we transition from acute to subacute. The focus shifts away from a simple cold and toward conditions like acute bronchitis or upper airway cough syndrome.
And what if we hit 3 months?
If a patient has been coughing for 3 months, entering the chronic phase, the differential diagnosis widens significantly. We must now actively investigate for COPD, hidden heart failure, a slowly growing lung abscess, malignancy, or even a persistent side effect from a daily medication.
That rule of threes is a brilliant mental shortcut for any listener trying to gauge the severity of their own situation. So let's use that framework to navigate the actual diagnostic flowchart provided in the clinical text.
The likely versus unlikely causes.
Exactly. If you walk into a pharmacy or a clinic, the professional is mentally sorting your symptoms. Starting with the heavy hitters in the likely category, we have acute bronchitis. This is the condition most people assume they have when a chesty cough settles in for the winter.
The acute bronchitis is incredibly common, particularly in the autumn and winter months. The predominant driving symptom is the cough itself, which can present as either productive or non-productive, depending on the exact stage of the inflammation.
What exactly is getting inflamed?
The bronchial tubes, which carry air into the lungs, become swollen and irritated. Because of this airway narrowing, you will often see the cough accompanied by a distinct wheeze, and the patient might report feeling mildly breathless upon exertion.
And systemic symptoms.
They may also have a mild fever, general malaise, and a sore throat from the constant mechanical trauma of coughing.
The timeline for acute bronchitis fits perfectly into that frustrating subacute window we outlined. It typically lasts for 7 to 10 days, but it has a habit of stubbornly persisting for up to 3 weeks as the bronchial lining slowly heals.
It lingers.
It does. But the most important takeaway from the clinical guidance regarding acute bronchitis is a point about treatment. Regardless of whether the underlying initial cause was a viral infection or a bacterial pathogen, the inflammation and the symptoms generally resolve completely without any antibiotic treatment.
This is a cornerstone of modern antibiotic stewardship. The body's immune system is highly capable of clearing acute bronchitis independently.
So doctors shouldn't be prescribing for it.
Providing antibiotics for a condition that will self-resolve only exposes the patient to potential side effects and actively contributes to population-level drug resistance. The clinical text explicitly advises that referral to a physician is only necessary if the patient is systemically unwell, meaning they are exhibiting signs of a broader, more severe infection beyond the localized bronchial inflammation.
If acute bronchitis is the obvious chest-rattling culprit, there is another highly likely condition that seems almost invisible. You might not even realize it's an illness. You just think you have a habit of clearing your throat. This is upper airway cough syndrome, or UACS. It is the stealth cause of a persistent cough.
UACS encompasses what was previously, and perhaps more commonly, referred to as postnasal drip. The mechanics of this condition originate not in the lungs, but high up in the upper respiratory tract.
So it's a nose problem, not a lung problem.
Exactly. It is characterized by excessive sinus, or nasal discharge, that instead of flowing out the front of the nose, physically flows backward, dripping down the nasopharynx and into the back of the throat.
Sounds incredibly annoying.
It is. This constant physical dripping mechanism directly irritates the sensory receptors in the pharynx and larynx. Patients typically present complaining of a runny or chronically blocked nose, an itchy throat, and an almost subconscious need to frequently clear their throat.
The prevalence of UACS is wild to me. The data suggests it is highly variable, affecting anywhere from 10% to an astonishing 80% of people in various populations.
It is incredibly common.
That means a massive portion of chronic throat clearers are actively dealing with this. The defining diagnostic question a pharmacist is trained to ask is, are you aware of swallowing mucus, or do you notice you are clearing your throat more than usual?
If the answer is yes, UACS immediately jumps to the top of the suspect list.
So what triggers it?
A significant proportion of UACS cases are fundamentally allergic in origin. If the underlying cause is an allergy, such as hay fever or a reaction to dust mites, the presentation has distinct features.
Like what?
The resulting cough is almost always non-productive. It is notoriously worse at night, because when the patient lies flat, gravity allows the nasal secretions to pool heavily in the back of the throat, maximizing receptor irritation.
That makes a lot of sense.
There is also usually a clear seasonal variation matching local pollen counts, and it will likely be accompanied by other systemic allergy signs like paroxysmal sneezing or itchy, watery eyes.
And treating it must be different then.
Crucially, yes. The standard management for UACS isn't a cough syrup aimed at the lungs. The treatment must target the source in the sinuses, using oral antihistamines or nasal decongestants to halt the drip itself.
So we have covered the likely infections and the stealthy nasal drips. Now we pivot to a fascinating section of the differential diagnosis, the, wait, that causes a cough category.
The unlikely suspects.
In a standard pharmacy presentation, these are listed as unlikely primary causes for an acute complaint, but they are incredibly common conditions in the broader global population. Here's where it gets really interesting. Let's look at medications, specifically a class of blood pressure drugs called ACE inhibitors.
Angiotensin-converting enzyme inhibitors, or ACE inhibitors, are a globally prescribed, highly effective class of medication used to manage hypertension and heart failure.
Millions take them.
Yes. However, they possess a very specific and highly prevalent adverse drug reaction. The clinical data reveals that ACE inhibitors are associated with causing a persistent cough in up to 16% of patients who take them.
16%.
That is an extraordinarily high incidence rate for a disruptive side effect in a chronic medication.
That means there are millions of people worldwide walking around with a chronic, dry, tickly cough simply because of their daily blood pressure pill. And what makes this side effect a diagnostic nightmare is its entirely unpredictable nature.
It defies standard drug logic.
It is not dose-related at all. A patient on a minimal dose is just as likely to develop the cough as someone on a maximum dose. Furthermore, the onset is completely random. A patient might develop the cough just a few hours after taking their very first pill, or, bafflingly, the cough can spontaneously emerge over a year into stable, symptom-free treatment.
It is so confusing for the patient.
Imagine being a patient trying to connect a brand new, persistent cough to a pill you have been taking safely every morning for 14 months. It is entirely counterintuitive.
It creates a complex puzzle for both the patient and the clinician. Often, patients will undergo extensive pulmonary testing, allergy trials, and chest x-rays before the medication is finally identified as the culprit.
Because it's the last thing they suspect.
And the only definitive solution is the complete withdrawal of the ACE inhibitor. But even then, the resolution requires immense patience.
It doesn't stop right away.
No. The clinical text notes that while the cough invariably stops after the medication is discontinued, it typically takes 3 to 4 weeks for the airways to fully calm down and the cough to cease.
Wow.
If a pharmacist identifies this connection, they must urgently advise the patient to discuss an alternative with their prescriber. Interestingly, a related class of blood pressure medications called ARBs, angiotensin II receptor blockers, have approximately half the incidence of cough compared to ACE inhibitors, making them a very common alternative.
So if you have been on an ACE inhibitor and you've had a dry, maddening cough for months, that pill bottle is a primary suspect. While ACE inhibitors are the main offenders, the text also notes that other medications like NSAIDs, sitagliptin, calcium channel blockers, and beta blockers are rarely associated with causing a cough. But it does happen.
It is always worth checking the medication list.
Moving down the list of uncommon acute presentations that point to chronic conditions, we have to look at asthma.
Asthma is a major global health issue, though its exact prevalence fluctuates based on differing diagnostic criteria globally. The text estimates it currently affects roughly 4% to 10% of the adult population.
And in kids?
In children, the incidence is noticeably higher, hovering around 10% to 15%, largely due to the fact that many children will experience symptom resolution as their airways mature into adulthood.
But that is still a massive number of people.
It equates to roughly 5.4 million people actively receiving asthma treatment in the UK alone. It is fundamentally a chronic inflammatory condition of the airways, characterized by a triad of typical symptoms: coughing, wheezing, and a feeling of chest tightness or shortness of breath.
While that triad is the classic presentation, the text highlights a specific, highly relevant variant for our deep dive called cough variant asthma.
This is a tricky one.
It really is. This is a presentation where the patient does not exhibit the classic wheeze or any noticeable breathlessness. The sole predominant symptom is just a persistent cough.
Which leads to misdiagnosis as a simple infection.
Exactly. If a patient, particularly a younger one, presents with a persistent cough that worsens at night and is clearly provoked by environmental triggers like cold air, exercise, or specific allergens, asthma absolutely must be considered, even in the complete absence of a wheeze.
Closely related in terms of respiratory impact, but distinctly different in its pathology and demographic, is COPD, or chronic obstructive pulmonary disease.
Right.
As of the 2022 data provided in the text, there were an estimated 1.4 million people living with diagnosed COPD, a condition that unfortunately accounts for roughly 30,000 deaths annually.
Sagital.
Unlike asthma, which often presents in childhood, the prevalence of COPD strictly and directly increases with age. Historically, it was a disease predominantly affecting men due to occupational and lifestyle differences, but current data shows it now affects both sexes equally.
The defining characteristic of COPD, alongside a chronic, highly productive cough, is a persistent breathlessness that relentlessly progresses over time. What makes COPD so insidious is how it masks itself in the early stages.
People just adapt to it.
The text notes that patients often do not even notice the early symptoms. Instead of recognizing a decline in lung function, they simply and subconsciously adjust their lifestyle. They start taking the elevator instead of the stairs, they walk a little slower, they avoid hills. They mask the symptom until the disease has progressed significantly.
And the primary risk factor is stark. 90% of people with COPD are current or former smokers, though a small minority develop it from long-term occupational exposure to industrial chemicals or dust.
How is it formally diagnosed?
Formal diagnosis of COPD requires spirometry testing to objectively measure the reduced airflow in the lungs. A critical feature of managing COPD is recognizing acute exacerbations. These are periods where the patient experiences a sudden, severe worsening of their breathlessness and a rapid reduction in their ability to perform daily activities, often triggered by a viral or bacterial infection.
Like adding fuel to the fire.
These exacerbations are medical emergencies requiring immediate referral to a GP for interventions like targeted antibiotics and systemic steroid therapy to force the airways back open.
Now let's explore one of the most bizarre and frankly terrifying conditions listed in the diagnostic text: vocal cord dysfunction.
This one is fascinating.
It perfectly mimics asthma in its presentation, but the underlying mechanical failure is entirely opposite.
It is a highly unusual physiological phenomenon. Normally, when you inhale, your vocal cords reflexively open wide to allow a massive volume of air to pass down into the trachea.
To get out of the way.
Exactly. In vocal cord dysfunction, this reflex malfunctions. The vocal cords intermittently and inappropriately close when the person inhales.
They close on the in-breath.
This sudden, unexpected closure drastically reduces the space for air to move, causing an immediate feeling of choking. Patients will exhibit hoarseness, frequent frantic throat clearing, and stridor, which is a loud, high-pitched breathing sound caused by turbulent airflow forcing its way through the narrowed cords.
The demographic for this malfunction is highly specific, isn't it? The text notes it is predominantly seen in females between the ages of 20 and 40, and whereas asthma is typically triggered by biological allergens, vocal cord dysfunction is often triggered by physical environmental shifts.
Strong chemical odors, sudden temperature changes, or intense exercise.
Imagine going for a run, inhaling a blast of freezing winter air, and having your vocal cords literally snap shut, suffocating you. It is a terrifying experience for the patient, and because it mimics an asthma attack so closely, it is constantly misdiagnosed.
The treatment is completely different, too.
Right. Recognizing the specific triggers and the mechanics of inhalation failure is crucial for proper treatment, which often involves speech therapy techniques to retrain the cords rather than standard asthma bronchodilators.
Rounding out this section, we must look at a condition specific to pediatric populations. Croup, which is clinically classified as laryngotracheobronchitis.
That is a mouthful.
It is. This is an acute viral infection that primarily affects very young children. The hallmark of croup is the highly distinct nature of the cough and the specific timing of the symptom onset.
Timing is key here again.
Croup almost exclusively strikes in the late evening and deep into the night. The resulting cough is severe, violent, and possesses a very distinct barking or seal-like acoustic quality due to the swelling on the vocal cords and trachea.
It really does sound like a seal.
Between these intense coughing fits, the child may exhibit severe respiratory distress, struggling to pull air through the narrowed airway.
That barking sound is a rite of passage for parents. It is something you absolutely never forget once you hear it echoing down the hallway at midnight. So we have thoroughly mapped the common viral infections, the stealthy postnasal drips, the unpredictable medication side effects, and the structural anomalies.
It is quite the map.
It really is. Now, we must transition to the most critical part of the clinical assessment. We are moving into the territory of serious pathologies and red flags. These are the underlying systemic issues where a cough is no longer just a localized irritation, but rather a blaring distress signal for a much larger, potentially life-threatening organ failure. When do we really need to worry?
This is the domain of the very unlikely but highly serious causes in a standard pharmacy presentation. We begin with heart failure.
Heart failure causing a cough.
While the general public associates heart problems with chest pain or arm numbness, the respiratory and cardiovascular systems are intimately linked. As the heart muscle weakens and fails to pump blood efficiently out to the body, hydrostatic pressure builds up in the pulmonary veins.
Back pressure.
Exactly. This pressure forces fluid backward, out of the blood vessels and into the delicate air sacs of the lungs. Heart failure is predominantly a disease of the elderly. The clinical data notes it affects roughly 1 in 7 people over the age of 85.
And it is a notoriously insidious disease. It doesn't happen overnight. It creeps up on the patient. The early symptoms are easily dismissed as just getting older, general fatigue, mild shortness of breath upon exertion, and paroxysmal nocturnal dyspnea, which is the terrifying experience of waking up gasping for air.
And as the heart failure progresses from mild to severe, you begin to see peripheral signs like intense ankle swelling.
And crucially for our deep dive, the fluid in the lungs triggers a chronic, productive, frothy cough. Because the fluid is mixing with blood from the pressurized pulmonary capillaries, the sputum may have that distinct pink-tinged appearance we discussed earlier.
And it worsens when they lie down.
Heavily worsens at night when the patient lies flat, as gravity allows the fluid to spread completely across the lungs.
The next major systemic threat is community-acquired pneumonia. This is a severe infection of the lung parenchyma itself, affecting between 0.5% and 1% of the entire UK adult population every single year.
That is a huge chunk of the population.
While viral pneumonias exist, bacterial infection is the predominant driver here, with Streptococcus pneumonia accounting for a massive 80% of all cases. Unlike the slow progression of a standard cold, the onset of pneumonia is striking and rapid, usually fully developing over a short 24 to 48-hour window.
The clinical text maps out the progression of a pneumonia cough very specifically, and it is a brutal timeline. For the first day or two, the cough is entirely non-productive, dry, and excruciatingly painful as the pleural lining becomes inflamed.
The pleuritic pain is intense.
Then, as the alveoli rapidly fill with pus and inflammatory fluid, the cough suddenly becomes highly productive. The sputum expelled is heavily stained a red or takes on that rust color as lung tissue bleeds. Concurrently, the patient will become obviously systemically unwell, exhibiting a high, spiking fever, profuse sweating, a rapid heart rate, and severe malaise.
When a patient presents with these symptoms in a clinical setting, doctors utilize a specific mortality risk assessment tool known as the CRB-65 score.
Tell us about this score.
This simple but highly effective score looks at 3 clinical signs: new onset confusion, a respiratory rate of 30 breaths per minute or more, and a low blood pressure reading, combined with the patient being 65 years of age or older.
So 4 factors total.
Each factor scores a point. If the patient's score is 0, indicating the lowest risk of mortality, the standard community treatment noted in the text is a prescription of amoxicillin 500 milligrams taken 3 times a day. A score of 1 or higher often mandates immediate hospital admission.
Moving from acute infections to chronic pathologies, there is lung cancer, or carcinoma of the lung. The statistics provided in the text are profoundly sobering. It stands as the 3rd most common cancer in the UK, with roughly 50,000 new cases diagnosed each year.
Its prevalence is strongly, almost entirely, related to increasing age and environmental exposure.
The tragedy of lung cancer is that in its early, most treatable stages, its primary symptom, a mild cough, looks exactly like any other benign respiratory condition. Because it hides so well, the clinical text provides a very rigid, clear red line for pharmacists and GPs to follow regarding referrals.
That referral rule is non-negotiable in clinical practice. High suspicion must be raised, and an urgent 2-week wait medical referral is mandatory for any patient over 40 years of age who presents with a new, unexplained cough, especially if that patient has a current or past history of smoking.
Any unexplained cough over 40 with smoking history.
Absolutely. If this unexplained cough is accompanied by other systemic red flags, such as breathlessness, dull chest pain, or unexplained rapid weight loss, the urgency of the investigation increases dramatically. The goal is to catch the malignancy before it alters the vocal cords or causes massive haemoptysis.
Shifting gears to a completely different anatomical system, we have GERD, gastroesophageal reflux disease. We associate acid reflux with heartburn, but it can absolutely present primarily as a chronic respiratory issue. The text notes that patients with GERD might complain of coughing specifically when they are recumbent or lying down in bed.
The mechanics here involve microaspiration and nerve stimulation. When lying flat, the highly acidic contents of the stomach can easily reflux up past a weakened sphincter and into the lower esophagus.
And it gets into the lungs.
This acid can occasionally microaspirate into the upper airway, directly irritating the lung tissue. But even if it doesn't reach the lungs, the presence of acid in the distal esophagus stimulates the vagus nerve, which, as we established in the anatomy section, shares pathways with the lung's sensory network.
So it tricks the brain.
Exactly. This shared neural pathway effectively heightens the overall sensitivity of the cough center reflex. Patients whose chronic cough is driven by GERD often respond exceptionally well to a trial of proton pump inhibitors which shut down stomach acid production. It is a mandatory consideration for any physician investigating a chronic cough with no obvious pulmonary cause.
And rounding out the list of serious systemic pathologies is a disease that feels like a historical ghost but is still very much a reality: tuberculosis, or TB. We tend to think of TB in sepia tones as a disease of the Victorian era, but the text provides hard data from 2021 showing 425 officially notified cases in England alone.
It has not gone away.
The distribution is highly concentrated in major urban centers. 35% of those modern cases were located in London, and another 21% in the West Midlands.
TB is a resilient, aggressive bacterial infection caused by Mycobacterium tuberculosis. It is transmitted from person to person strictly via the inhalation of aerosolized droplets. Unlike the rapid 48-hour onset of pneumonia, TB is characterized by a very slow, insidious onset.
It takes its time.
The bacteria can lie dormant for years before actively multiplying and destroying lung tissue. The resulting cough is profoundly chronic, and the accompanying symptoms are heavily systemic rather than just localized to the chest.
Like what?
A TB patient will often suffer from drenching night sweats, unexplained and significant weight loss, anorexia, and a profound, lingering general malaise. Sputum production varies wildly depending on the stage of the cavity formation, and while coughing up blood is a famous hallmark of the disease in popular media, clinical data shows haemoptysis is actually a late-stage feature indicating advanced structural damage.
So, synthesizing all of that complex pathology into a definitive, practical red flag checklist. If you are listening to this, analyzing your own lingering cough or the cough of a family member, and wondering, when must I bypass the pharmacy and go straight to a doctor? The clinical text gives us an absolute, rigid list of symptoms.
Non-negotiables.
You must seek urgent medical attention if your cough is accompanied by any of the following: sharp chest pain, pain specifically upon inspiration, which is when you breathe in, a noticeable wheeze or new shortness of breath, coughing up blood of any amount, sudden unexplained weight loss, or if you are an older adult experiencing debilitating, exhausting symptoms that prevent you from functioning.
And the timeline rule.
And of course, the ultimate temporal golden rule. If any cough, no matter how mild, extends past that 3-week acute window, it is time to get it formally evaluated by a professional.
Those red flags are the absolute non-negotiables of respiratory triage. If you experience them, the pharmacy is no longer the appropriate venue for your care.
But most coughs don't have those red flags.
No, they don't. However, the vast majority of coughs do not present with red flags. What happens when you just have a standard, miserable, day 5 viral cough? You are exhausted, your ribs hurt, and you walk into the pharmacy desperate for a bottle of relief.
Which brings us to the final and perhaps the most paradigm-shifting portion of this entire deep dive. We are calling it the pharmacy illusion.
Prepare to have everything you thought you knew about those colorful rows of cough syrup fundamentally challenged.
We are now going to scrutinize the actual peer-reviewed evidence base for the over-the-counter medications that generate billions in sales every winter. Let's look at the landmark data that completely upends the industry.
The clinical text grounds its pharmacological assessment in a comprehensive, highly respected 2014 Cochrane review.
And Cochrane is the gold standard, right?
For context, Cochrane reviews are considered the gold standard in evidence-based medicine. They ruthlessly aggregate and analyze all available trial data on a given treatment. This specific review examined the treatment of acute coughs in both adult and pediatric populations.
And what did they find?
After analyzing the entire global body of evidence, their conclusion was incredibly blunt and highly disruptive. They found that there is no good evidence to support the effectiveness of any over-the-counter cough medicines in treating acute coughs.
None. Zero good evidence. That is a staggering conclusion. How is it economically or legally possible that entire massive aisles of every pharmacy on Earth are dedicated to these products if the gold standard of medical review says they essentially do not work?
The explanation lies in history and the evolution of medical standards. The text clarifies that virtually all of these active pharmacological ingredients were formulated and brought to market many decades ago.
Long before modern trials.
Right, long before the establishment of modern, rigorous, double-blind clinical trial requirements. Back in the mid-20th century, clinical trials suffered from severe, systemic flaws in study design, small sample sizes, and subjective reporting.
Plus the nature of the cough itself.
Furthermore, testing a cough medicine presents a unique methodological hurdle. An acute cough is, by its very nature, a self-limiting condition. It is programmed to go away on its own within 3 weeks. Therefore, in a poorly designed trial, it is almost impossible to definitively differentiate between a medicine actually altering the disease course and a patient simply naturally recovering over time.
The old drugs were just grandfathered in.
And the modern data simply cannot validate their initial claims.
So we have an industry built on a historical lack of demonstrable efficacy. But the issue is not just that they might be useless placebos. The text highlights severe, growing safety concerns that have finally forced the hands of regulators.
The bans have been rolling in.
Over the last decade, regulatory bodies have been aggressively cracking down on these old formulations. Let's trace the timeline of these regulatory smackdowns in the UK because it shows how quickly the shelves are emptying of active ingredients.
The regulatory landscape began a major shift in April 2015. The Medicines and Healthcare Products Regulatory Agency, the MHRA, issued a sweeping directive advising all healthcare professionals to immediately restrict any prescribing or dispensing of codeine-containing cough medicines to anyone under the age of 12.
Codeine.
Codeine is a powerful opiate, and this restriction was driven by a stark combination of factors. A complete lack of proven efficacy for cough suppression in children, paired with the very real, documented potential for severe harm, specifically life-threatening respiratory depression.
Codeine was a staple of childhood medicine cabinets for a century, and suddenly it was deemed entirely unsafe for kids. Following that ban, manufacturers scrambled to reformulate their syrups, relying heavily on two other suppressants, Volcadine and dextromethorphan.
But the regulatory net continued to tighten.
The text outlines another massive, highly disruptive shift that occurred very recently. In March 2023, the MHRA announced the complete, immediate withdrawal of Volcadine from the entire UK market due to concerns over sudden, severe allergic reactions when patients were subsequently exposed to general anesthetics.
That 2023 withdrawal fundamentally altered the pharmaceutical landscape. As the clinical text states, looking at the shelves as of spring 2024, the treatment of non-productive dry coughs with an over-the-counter pharmacological suppressant is now entirely exclusively limited to one single remaining active ingredient.
Dextromethorphan.
Dextromethorphan.
Dextromethorphan is the last man standing in the battle against the dry cough. Given its monopoly status, you would assume it has incredibly robust clinical data proving it works miracles. What does the evidence actually show?
Unfortunately, its monopoly is based on survival, not superior efficacy. The trial data for dextromethorphan is surprisingly weak.
How?
Returning to that definitive 2014 Cochrane review, researchers could only identify 3 methodologically reliable studies comparing dextromethorphan against a simple placebo in adult populations. 2 of those 3 studies did find a measurable improvement. However, that improvement was incredibly modest.
What are the numbers?
It equated to an average drop of about 8 to 10 coughing bouts over a 30-minute observation period compared to the placebo group.
Okay, so if you take a dose, you might cough 8 to 10 fewer times in a half-hour window. That is a measurable physiological effect, but it is hardly a complete suppression of the reflex. And that was only in 2 of the studies.
Correct. The third, highly rigorous study found absolutely no statistical difference whatsoever between dextromethorphan and a placebo, either in terms of objective cough frequency, nor in the subjective symptom scores reported by the patients.
So it's barely better than doing nothing.
However, while its efficacy is debatable, its side effect profile is generally considered safer than codeine for the general public. But the clinical text mandates a very serious warning regarding severe, potentially fatal drug interactions that patients rarely consider when buying a simple cough syrup.
This is a critical safety warning. Dextromethorphan is structurally related to opiates, and it effectively crosses the blood-brain barrier to interact with the central nervous system. If a patient mixes a dextromethorphan syrup with alcohol, opioid analgesics, anxiolytics, hypnotics, or standard antidepressants, the drug interaction will significantly amplify the sedative effects.
You could become dangerously, unexpectedly drowsy, making driving or operating machinery highly hazardous.
Beyond sedation, the more critical pharmacological risk is the induction of serotonin syndrome.
This is serious.
Dextromethorphan inhibits the reuptake of serotonin in the brain. If it is inadvertently mixed with prescription drugs that also elevate serotonin levels, such as MAOIs, common SSRI antidepressants, or the widely prescribed painkiller tramadol, it can trigger a massive, uncontrolled, and potentially life-threatening buildup of serotonin in the body.
Symptoms of serotonin syndrome range from shivering and diarrhea to severe muscle rigidity, fever, and seizures.
The text is clear. If a patient is on any psychiatric medication or heavy pain management therapy, they must have a comprehensive consultation with a pharmacist before purchasing dextromethorphan. For those over 12 where it is deemed safe, the standard dose is 10 milliliters taken 4 times a day.
So that thoroughly covers the suppressant side of the aisle, and it's shutting down the dry cough. Now let's walk over to the expectorant side of the aisle, which promises to help you forcefully clear out a productive chesty cough.
The clinical text provides a historical anecdote regarding the origins of expectorants that is absolutely mind-boggling. Let's examine the medical logic behind older ingredients like ammonium salts, ipecacuanha, and squill.
The history of pharmacology is often deeply ironic. Traditionally, those specific botanical and chemical ingredients were utilized in emergency medicine strictly as powerful emetics.
Meaning they make you vomit.
Exactly. Their sole pharmacological purpose was to violently induce vomiting in cases of poisoning.
So how did they end up in cough syrup?
The theoretical mid-20th century basis for including these vomiting agents in cough medicine was based on dosage. The logic dictated that by administering them at lower subemetic doses, meaning a dose precisely calibrated to be just below the threshold of actually making the patient throw up, they would cause severe, persistent gastric irritation.
That just made your stomach hurt.
The medical hope was that this intense, localized stomach distress would somehow trigger a systemic vagal nerve reflex that would agitate the respiratory system enough to promote the expectoration, or coughing up, of lower airway mucus.
That logic perfectly illustrates how wild medical science used to be. The prevailing strategy for a chest cold was essentially, let's make the patient feel profoundly nauseous and deeply uncomfortable in their stomach, and maybe, just maybe, that gastric agony will cause a reflex twitch in their lungs that helps them cough up phlegm.
And the clinical text dryly, almost humorously notes, this mechanism has never been proven.
I think we can all be incredibly grateful that modern medicine has abandoned the strategy of intentional nausea. So, moving away from Ipecac, what is the modern, non-nauseating expectorant that dominates the market today?
Almost all products currently marketed and sold in the UK, intended for the treatment of a productive, chesty cough, rely entirely on a single active chemical ingredient, guaifenesin. Pharmacologically, guaifenesin is thought to stimulate the secretion of respiratory tract fluid. By introducing more water into the airways, it theoretically increases the total volume of your sputum while simultaneously decreasing its viscosity, making the thick mucus thinner, looser, and mechanically easier for the cilia and the cough reflex to push up and out.
A thinner, looser mucus sounds exactly like what a chesty cough needs. But again, we must subject it to the Cochrane standard. What does the actual modern clinical evidence say? Is guaifenesin the miracle drug the commercials claim it to be?
The evidence base is, at best, highly conflicting. It holds the distinction of being the only active expectorant ingredient with any documented evidence of effectiveness. But that evidence rests on a very shaky foundation.
Let's hear the data.
The systematic review evaluated 3 primary studies. The largest of the 3, which tracked 239 participants, did yield a positive result. Patients reported a statistically significant reduction in both cough frequency and subjective intensity compared to those taking a placebo.
Okay, that sounds promising.
However, a smaller parallel trial involving 65 people found absolutely no measurable effect whatsoever.
And the text details a more recent, larger study with 378 people that looked specifically at an extended-release, high-dose version of guaifenesin. The researchers tracked the patients over a week. They found absolutely no difference in symptom resolution between the drug and the placebo by day 7. They did, however, find a very slight, mathematically measurable reduction in symptom severity, specifically on day 4. The drug group reported a severity score of 5.7 out of 10, while the placebo group reported 7.1.
But the clinical text literally prints the caveat: the clinical significance of this difference is uncertain.
It ultimately concludes that based on the aggregate data, guaifenesin is probably little or no better than a standard placebo.
Despite the lack of robust efficacy data, the clinical text does offer a highly pragmatic defense for the continued sale of guaifenesin. Unlike dextromethorphans and the older, banned opiates, guaifenesin possesses an exceptionally proven long-term safety record.
It won't hurt you.
It boasts virtually no adverse side effects, does not cross the blood-brain barrier to cause sedation, and is completely free from any clinically significant drug interactions. Given that the general public has a deeply ingrained, almost psychological desire to actively treat a chest cold with a tangible home remedy, the text concedes that it is perfectly reasonable and clinically ethical to supply guaifenesin over the counter.
It almost certainly won't harm the patient. It provides a safe placebo action, and it might provide a tiny subjective benefit. The standard recommended dose is 200 milligrams taken 4 times a day for adults and children over 12.
Moving further down the pharmacy aisle, we encounter the antihistamines. Ingredients like diphenhydramine have been foundational components in nighttime cough medicines for decades.
The logical assumption most patients make is that since a cold gives you a runny nose and sneezing, much like an allergy, an antihistamine must work by stopping that histamine-driven allergic reaction in the lungs.
That is a very understandable, yet fundamentally flawed assumption. The clinical text clearly clarifies that for coughs induced by viral colds, the mechanism of action for these older drugs is not related to histamine blockade at all.
So what are they doing?
Viruses do not trigger a massive histamine release in the way pollen does. Instead, these drugs rely entirely on their secondary anticholinergic side effects. Anticholinergic drugs block the neurotransmitter acetylcholine, which results in a systemic drying action across all mucous membranes in the body.
So the goal isn't to fight the virus or the allergy, it is simply to aggressively dry out the entire respiratory tract so there is less fluid available to drip or pool. But does this systemic desiccation actually reduce the frequency of the cough?
The evidence supporting that outcome is remarkably unsubstantiated. While some highly artificial laboratory studies, where researchers chemically induced coughs in healthy volunteers using citric acid sprays, showed a minor suppressive effect, the actual clinical trials involving sick patients in the real world are plagued by terribly small sample sizes and poor methodological design.
So it works in a lab, but not in real life.
Exactly. The text quotes a definitive medical review stating that the historical presumptions about diphenhydramine's efficacy against infectious coughs are simply not unequivocally substantiated in literature. Furthermore, when researchers tested newer non-sedating antihistamines, the kind you take for daily hay fever that don't make you sleepy, they found absolutely zero clinical benefit against a cold-induced cough compared to a placebo.
And the side effects of those older, highly sedating antihistamines like diphenhydramine are very real and systemically disruptive. Because they block acetylcholine everywhere, you don't just get dry lungs. You get profound sedation, a painfully dry mouth, dizziness, and gastrointestinal slowing leading to constipation.
The text issues a specific warning regarding those antimuscarinic drying properties.
Yeah.
Individuals with specific anatomical vulnerabilities, such as those with glaucoma or older men with benign prostate enlargement, should ideally avoid them entirely.
Why is that?
The systemic drying effect can dangerously increase intraocular eye pressure or suddenly precipitate acute urinary retention.
The clinical text provides exactly one pragmatic caveat regarding these older antihistamines. The intense sedative side effect, while technically an adverse reaction, can occasionally be clinically useful simply to allow an exhausted, suffering patient to finally achieve an uninterrupted night of sleep.
It knocks them out.
The drug acts as a chemical sledgehammer, knocking the patient out so they don't notice the cough. But it must be understood that the drug is merely inducing sleep. It is not actively treating or shortening the duration of the underlying cough pathology.
So, synthesizing the pharmacy evidence. We have debunked the suppressants as largely ineffective and potentially dangerous when mixed. We have revealed the expectorants to be historical curiosities that offer little more than a safe placebo effect, and the antihistamines are just drying agents with a heavy dose of sedation.
What is actually left that works?
This brings us to the demulcents. These are products like simple linctus syrups, glycerin, and good old-fashioned honey. The clinical text classifies these as pharmacologically inert. They contain no active drugs.
They're essentially pure viscous placebos that operate entirely on the physical theoretical basis of coating the inflamed pharynx to temporarily shield the sensory receptors from irritation.
That physical coating action is the exact mechanism, and this is where the clinical text reveals perhaps the most surprising and validating piece of positive evidence in the entire deep dive.
I love this part.
While commercial simple linctus has no rigorous evidence backing it, a massive 2018 Cochrane review specifically explored the traditional use of honey for treating acute coughs in pediatric populations. This was not a small study. It was a substantial, rigorous review encompassing 6 separate high-quality trials involving a total of 899 children.
And the results of testing the oldest home remedy in the book against modern pharmacology.
The Cochrane review found moderate to low quality yet statistically significant evidence that honey was actually more effective than taking absolutely no treatment, and crucially, more effective than a standard pharmaceutical placebo syrup.
Wow.
Specifically, the data demonstrated that administering a dose of honey for up to 3 days is probably more effective in actively reducing the overall duration and severity of acute cough symptoms in children compared to the commercial alternatives.
That is an absolutely amazing revelation. We spend billions of dollars chemically engineering suppressants and expectorants, and the remedy that actually demonstrates a measurable, verifiable clinical benefit in a modern gold standard review is created by bees. Honey unequivocally wins the evidence war.
It is a profound victory for traditional remedies. Honey is fundamentally safe, highly effective as a physical demulcent, cheap, and highly recommended by modern clinicians. The only absolute medical caveat, which is standard pediatric practice, is that honey must never be given to an infant under 1 year of age, due to the rare but severe risk of infant botulism from spores that can naturally occur in raw honey. But for anyone older than 1, it is the premier choice.
What about the rest of the shelf? The combination products or the herbal boxes? If you look closely, there are so many bright boxes promising to do 5 different things at once. Suppress the cough, clear the nose, lower the fever, and loosen the chest.
The clinical text is quite firm and highly critical on this specific category. Medical professionals strongly advise avoiding combination products whenever possible. Firstly, many of these all-in-one liquids contain subtherapeutic doses of their active ingredients.
Meaning the manufacturer puts in just enough of the drug to legally list it on the box, but the dose is far too low to have any actual physiological effect on your body.
Secondly, and more concerningly, some products contain entirely illogical pharmacological combinations. For example, it is not uncommon to find a syrup that simultaneously contains a cough suppressant, which actively tries to paralyze your cough reflex, mixed with an expectorant, which is actively trying to stimulate your lungs to cough more forcefully.
It is a chemical tug-of-war occurring inside your body that serves no rational medical purpose.
It is the definition of a pharmaceutical oxymoron. Why would you pay money to take two drugs that cancel each other out?
And what about the rising popularity of herbal ingredients? We see a lot of syrups heavily marketing thyme, ivy leaf extract, and primrose root.
The rigorous review data on commercial herbal products is highly dismissive. The analyses found only very low-quality evidence suggesting any potential reduction in cough frequency or severity compared with a simple placebo.
To save your money.
The clinical text explicitly concludes that while products heavily featuring ingredients like thyme and pelargonium are widely commercially available and heavily marketed, based on the stark lack of current high-quality evidence, they should simply not be routinely recommended by pharmacists as clinical treatments.
Okay, before we bring all of this together, there are two crucial, highly specific hints and tips tucked away in a clinical advisory box in the text that we absolutely must pass on to you as they deal with immediate safety. First, a vital warning regarding diabetes.
Yes, this is a systemic metabolic issue. If you have insulin-dependent diabetes, you must be hypervigilant and monitor your blood glucose levels much more frequently during any acute respiratory infection that results in a severe cough.
Because of the stress.
The physiological stress of the viral infection, combined with the immense physical exertion of violent coughing, directly and significantly increases your body's base insulin requirements. Blood sugar levels can spike unpredictably during a seemingly standard cold.
That is incredibly important for any diabetic patient or caregiver to know. A simple cold can completely destabilize glucose management. And the second clinical tip concerns a specific older respiratory medication called theophylline.
Theophylline is a bronchodilator that is technically still available as a pharmacy-only medicine in the UK, meaning you can request it over the counter without a prescription. However, the clinical text strongly, definitively advises patients to avoid seeking it out for self-treatment.
Why shouldn't they buy it?
The logical reasoning is structurally sound. If a patient is experiencing airway constriction, shortness of breath, or an audible wheeze to the severe degree that they are actively seeking out a powerful drug like theophylline, they are, by definition, exhibiting clinical red flag symptoms.
They are too sick for the pharmacy.
They do not need a pharmacist to hand them a pill. They urgently require a comprehensive physical assessment by a medical doctor to rule out an asthma exacerbation, COPD failure, or pneumonia.
Perfect. Okay, we have covered a truly immense amount of medical ground today. We've mapped the intricate, high-speed neurological pathway of the medulla's cough reflex, debated the cellular battlefield that changes the colors of our sputum, navigated the complex diagnostic flowchart from invisible postnasal drips to the bizarre reality of ACE inhibitor side effects.
We really went through it all.
We've identified the non-negotiable red flags of serious lung disease, and we have systematically, clinically dismantled the multi-billion-dollar illusion of the over-the-counter pharmacy aisle. So what does this all mean for you the next time you feel a tickle in your throat?
It means that a cough is almost never the disease itself. It is merely a symptom. It is a highly tuned, evolutionarily ancient biological defense mechanism perfectly designed to keep your airway clear and keep you alive in a world full of microscopic threats.
And most of the time, it resolves itself.
The vast majority of the time, this alarm is triggered by a standard viral infection, and it is entirely self-limiting. The human body is exceptionally proficient at repairing itself, provided it is given that normal 3 to 4 week window to rebuild the respiratory lining.
And it means that the brightly colored pharmacy aisle is largely filled with expensive historical relics, outside of maybe dextromethorphan giving you a very slight 8-cough edge for a dry throat, guaifenesin providing a safe, watery placebo effect for a chesty rattle, and the scientifically proven ancient relief of good old-fashioned honey. Modern pharmacology simply does not possess a magic bullet to silence the common cough.
If we connect this to the bigger picture of human health, it raises a deeply important, almost philosophical question. Given how incredibly complex the physiological cough center reflex is, involving multiple cranial nerves, the brainstem, and precise instantaneous muscular coordination, And given how completely ineffective modern pharmacology is at safely or efficiently suppressing it, we have to seriously wonder about our society's entire approach to respiratory medicine.
That is a fascinating pivot. Where are you going with this?
Well, instead of continuing to pour millions of dollars into developing new syrups and synthetic suppressants designed to aggressively turn off this ancient biological alarm system after it has already been triggered by an irritant, perhaps the future of respiratory medicine shouldn't be focused on the pharmacy aisle at all.
What should we focus on?
Should we instead be focusing entirely on proactively modifying our living environments? If we invested heavily in vastly improving our indoor air quality, radically reducing our daily exposure to particulate pollutants, and perfectly managing building humidity levels so our delicate mucous membranes never dry out.
We stop the trigger entirely.
Essentially, engineering our modern lived environment so the human body never feels the physiological need to pull the fire alarm in the first place.
Wow. That is a completely different, profoundly structural way to look at respiratory health. Stop trying to invent better ways to silence the alarm and focus all our energy on putting out the fires before they even have a chance to start. I absolutely love that perspective.
It is certainly significant food for thought the next time you hear someone hacking relentlessly on the train during the morning commute.
It definitely is. Thank you all so much for coming on this incredibly detailed physiological journey with us today. We hope you stay intensely curious, keep learning about the amazing, complex ways your body works to protect you, and please think twice before demanding an unnecessary antibiotic the next time you cough up a little green cellular debris. Let your mucociliary escalator do the heavy lifting, have a spoonful of honey, and just give your body some time. We will see you on the next deep dive.